Okay. Namaskar. This is Dr. Alok Roy again from Medica Hospital, Kolkata. And like every week, this Saturday, we are with you under the webinar banner of Health is the Ultimate Wealth. Last week, we covered about the adults, that what are the monsoon problems which they can go through. This time we thought that we must talk about children. How do we prevent them from falling sick during monsoon? And today I have none less than Dr. Nicola Flynn. She is our Health Department of Pediatrics and Neonatology. She is a very competent doctor. Not only she is a good doctor, she's also a very good human being. With this, without wasting time, I would pass on the mic to Dr. Nicola Judith Flynn to take you through monsoon melodies in children. Nicola, over to you. You are on mute, Nicola.
Good evening, everyone. Thank you, sir, for that very kind introduction of me, sir. And as the caption in the background says, health is ultimate wealth. It's very true. And especially as all parents are very concerned, especially after this, we have gone through this pandemic regarding the health of these children. And now with schools opening, we're all worried about the rise in infections. To top it up, we have the monsoon season, which has also arrived in correct time. So I've termed my talk as monsoon maladies, because the malady means an affliction, a disease, an impairment of function. So I've called it monsoon maladies, and I'm going to discuss in my talk two things. One thing, what are the common diseases that our children are going to be faced with this monsoon? And also, which of them can be prevented by vaccines? So I'll go ahead with my talk. And so why monsoon maladies? You know, everyone says hawata palte jache, it's a change of weather. Well, it actually is a change of weather, because changes during the monsoon, we do face sudden changes of temperature. There are changes in humidity. Now, due to these changes of temperature and humidity and various other changes in the environment, there is more growth and survival of germs, especially the viruses. More contamination of drinking water, so therefore increase in foodborne diseases, and transmission of germs through food, air, water, hands, flies, mosquitoes increases. Now, as with anything, while we're talking about anything, it's important to really classify any particular topic that we are talking about. It makes our understanding a lot easier. Now, in this first picture, I've actually shown polluted water pools, a common sight in various canals and drains around the city. This is a more rural picture, and more of the many diseases, fevers, coughs, colds, diarrheas, dysenteries. During this monsoon season, we also encounter, especially as you go towards the rural areas, and we do receive referrals from these places with animal bites, especially the snake bites, but this is beyond the scope of our discussion today. We also notice that ward admissions and OPDs have more patients. Now let's classify the maladies and look at them, so it helps us to better understand. And if we better understand, so we can tell parents and colleagues and friends how to better protect our children from these maladies. So first we have the vector-borne diseases, water and food-borne diseases, air or droplet-borne diseases, animal bites, especially snake bites. Okay, so the vector-borne diseases we'll start with. We have the very common ones, malaria, dengue, and chikungunya fever. Today, I'm going to basically discuss more of dengue, because this is the one in which we see the maximum morbidity and mortality in children, because the fever has been taken for granted at home, and by the time the child comes, it is quite late. Malaria, I must say, whether it is the dengue which has taken over, or whether it is the COVID which has taken over everything, we hardly get to see any malaria these days compared to what we used to see as postgraduates and even after that. So looking at malaria, this is a very common disease in the tropics and the subtropics, and some types like the falciparum types are very dangerous. It's spread by the Anopheles mosquito, which breeds in fresh water and pools and drains, lakes and streams. It does present with fever with chills. Also, we need to remember that fevers and chills in a child can also be caused by UTIs. Fevers by itself in a child, even viral fevers, can cause chills in children. So let's not always jump to the diagnosis of malaria, but we need to sort of keep it in mind. Fever usually alternate day if it's a typical presentation. In children, usually those rhythms are not followed. So you may get fevers that are not subsiding. You may get fevers that come every second or third day. Simple treatment is available once you do a blood smear and it's diagnosed to be malaria, or you do an antigen test and it's diagnosed. We have chloroquine for the simple type and artesunate for the dangerous type. So here's the Aedes mosquito just after a good blood meal, and it's full of blood. So now we come to dengue. So the symptoms of dengue, here I would like to lay a little stress, because dengue again starts off with fever. Now usually in children the fever comes, it may be mild grade, moderate grade or high grade fever, which is treated by the parent more or less at home with paracetamol or ibuprofen or something, whatever they have at hand. The fever generally subsides after a day or two. There's an afebrile period where the parent thinks that the child is perfectly okay, and then the next spike occurs with all the complications. So I always counsel my parents that, if the second spike is occurring, please don't keep treating it with antibiotics that are available over the counter, with ibuprofen, because that is dangerous. And that's the time you need to seek help. Well, if the fever is subsided and not come back, then parents don't need to worry. But if the fever has come back, the first thing they need to do is get in touch with a health facility. So the fever, in bigger children, they'll complain of headache, but now a lot of small children also complain of headache. We have a more vocal younger generation at present. Muscle pains, joint pains, and the rash which comes up later. Once the rash comes up, we are pretty much into the disease. So also the reason why I have written that it is similar to measles, because in West Bengal, most of them will come to you saying that jor hoyeche, tarpore ham hoyeche. So they think it's measles, but it's not. There is a differentiation of the rash. So dengue fever, the febrile phase, there'll be sudden onset fever. The parent will typically tell you, je kono jor, thanda, kashi kichu chilo na. The child just had fever, a bit of, a headache. And then later on, mouth and nose bleeding, sometimes gum bleeding occurs when the platelet counts are low. There's muscle pains, There's muscle pains, vomiting, then the rash comes up, there's diarrhea. The critical phase is when we receive the children most of the time. It's very rare. I think since I've joined in Medica here, we had one child, and that child actually came to us with symptoms of diarrhea, dysentery, and fever. And then we investigated because the platelet counts were low, and we found that the child was dengue positive, and it was an uncomplicated dengue. So the child was treated just conservatively with IV fluids, and then switched to oral fluids and antipyretics, and the child went home. The critical period is when we see most of them presenting late in the night in the ER. And that's the time the child will be listless, and there'll be low blood pressure, and then there is effusion, there's ascites, and there's gastrointestinal bleeding, there's blood in the stools. And that's the time the child requires an ICU care. Now, if the child comes to you before that or well in time, and the child is treated as per the protocol for dengue, then you have to be very careful with the fluids during the recovery phase, because when the re-entry occurs, you don't know when that's going to occur. And if your fluids are not really titrated and targeted, then you end up in a overload state, and you can lose the child like that. Now we come to the waterborne diseases. Now, because of water contamination, which happens a lot in the monsoons because of flooding, and then, water overhead tanks not being cleaned regularly, and some seepage into these tanks because they're very old tanks, we have the usual run of the diarrheas. Dysenteries. Well, there has been a Shigella outbreak this year, and in our hospital, in our pediatric department itself, we have seen a 5-6-year-old child who came with severe diarrhea, dysentery, and there was a Shigella had grown from the stool and the blood culture of the child. The child was very sick, had a CRP as high as more than 200, spiking fever, ill child, and we had to shift the child to the PICU isolation. And we treated this child with the sensitive antibiotics. The child got well and went home. Hepatitis A is another thing which is very commonly seen in children. Now, most of these infections may be asymptomatic, short-lived, and the child gets through it. But there are a certain subset of children that do come with symptoms of icterus and nausea, vomiting, and the whole cascade of events. The fourth one is typhoid, which is also on the rise right now. We've also had Salmonella positive children in the last 2 weeks in our unit, and we've treated them. They've all been sensitive to the common antibiotics, fortunately. So the childhood diarrheas. Now, the main thing about childhood diarrheas is that the parent should be aware that they don't allow the child to get into dehydration. It is okay to treat a child who has maybe 3, 4, 5 loose stools with home available fluids and ORS. I request here all as always, as I tell them in my OPD and even when I speak publicly, please do not resort, parents, to giving your children the noon chini jole ghol, the saltwater solutions. We need to remember one thing here, that those salt water and sugar solutions were used in the days in which there was no ORS readily available. WHO and the PHC system and the over-the-counter drug system that is in place here is in India right now. You have ORS, especially formulated for pediatrics, that is available, and only that should be given. Why? Because you see, in a glass of water, when you put a pinch of salt and when you put some sugar and you stir it, you don't know in milli equivalents how much of or how many grams of sugar you're putting and how many milli equivalents of sodium you're adding. If there is an electrolyte disbalance due to that, the child will become worse and the dehydration increases, and therefore the morbidity and the mortality is going to increase. So I always teach parents, okay, if your child is having a loose stool or two, you can manage it at home, but know the danger signs. Is the child's mouth dry? Have a look. Is the child getting very lethargic? Is the child refusing to drink? So these are the few things I ask parents to always look at. And lethargy, of course, is quite a late sign of dehydration. So I keep asking them, see if the eyes are glistening, like normally our conjunctiva glistens. If it's shiny, look at the mouth and see if the child is willingly wanting to accept. Even if the child is willingly wanting to accept fluids, it means it's the early stage of dehydration if there's any dehydration. Now, diarrhea in childhood, especially the under 5 diarrheas, some of them can be killers like rotavirus diarrheas, and it is vaccine preventable, and we'll be talking about that once we go to the vaccine section. Typhoid. Now, typhoid, as we all know, or the entry group of fevers, if there's continuous fever, the child has high spiking fever, the fever will not touch the baseline, even with good antipyretics given in a correct dose. The child is ill, there's abdominal pain, so change of bowel habits. So usually in adults, typhoid causes a bit of constipation. On the other hand, in children, we have a little diarrhea. Children are different, so the symptoms are also different, even with the same germ. So they have changed bowel habits, they may have a little diarrhea. The blood tests that we do initially are typhoid, it's not very sensitive, but then for a Vidal to be sent, which is a confirmatory test, you need to have fever for about 5 to 7 days. Of course, the gold standard for confirmation of typhoid is the blood culture. So if we get a Salmonella group of organisms, we'll say, well, it's typhoid. So the first week, the illness is moderate. In the second week, the illness gets worse, and child can have diarrhea with blood in the stools, and this can be a serious emergency. Also, sometimes the children stop passing stools. There is a distended abdomen, the child does not pass flatus, and then there can be very well signs of a perforation that has happened. Child will be very acutely sick. You cannot even touch the abdomen. The abdomen is absolutely rigid. Again, preventing typhoid. So food safety, clean drinking water, avoiding outdoor food, which is a little, I find, difficult today. I think in the age in which I grew up, which was not very long ago, eating out was a big thing. Maybe it happened twice a year or thrice a year, or sometimes, you know, even less than that. But today, a child today really thinks that it's great if they can get to eat out once a week at least. So public water supply safety. This is also vaccine preventable, and the IAP has gone out in a big way with these typhoid vaccines to prevent typhoid. So that's why we actually get to see less cases compared to what I saw as an MBBS student in the mid-90s and later on even during my post-graduation years. Now the vaccine has been reduced to a single dose. Initially, I'll talk about the history of the typhoid vaccine when we go to the vaccine section. The other waterborne or foodborne disease, which is spread by the fecal-oral route, is hepatitis A. Diseases are mild to severe, but children do get affected. Now, most of the children actually reach us in the anectic phase when there's just anorexia, there's fever, there's abdominal pain, there's a lot of, you know, nausea and malaise and discomfort. At that time, the bilirubins are all normal. There's no icteric on general examination, but you could actually trace a sort of a kind of a rise in the enzymes that occur. So we first usually see the enzymes rising, then later on we'll see the bilirubins coming up. So not everyone, again, who's infected with hepatitis A will have all of the symptoms. And again, in children, it varies, especially when the children are younger children. Prevention of hepatitis A can be reduced by, again, safe drinking water, you know, the sewage being maintained properly, personal hygiene practices, regular hand washing with clean water. Vaccine is also available, 2 doses if necessary. And for travelers, there are 2 varieties of the vaccines. We'll come to that during the vaccine section. And this is especially recommended for high-risk groups that are, you know, children who are going out, eating often, or parents who need to travel often with their children and things like that. So now we come to the air or the droplet-borne diseases. So the various range, it's a spectrum. It can be from just the common cold and flu, cough and cold, various viral fevers to something as harsh as influenza. So in influenza, what happens is, so the coughs and colds, which we can treat symptomatically at home. I always tell parents, please wait for 3 days, see if things are getting worse. Is the child having any fast breathing, any difficulty to breathe, please go to the nearest health facility or come to our OPD, show us so that we know what's going on. We can evaluate the child. So often called viral fevers, you know, we all say they're all viral. If there is a sharp peak in the rainy season, it's self-limiting. As we were taught in our MBBS that, you know, a cold that is treated lasts 1 week, but an untreated cold lasts 7 days. So it's self-limiting. And simple remedies, I even recommend, you know, don't give syrups and various other formulations. Just keep the child's nose clear. You can give a bit of steam inhalation. You needn't always use medicated nasal drops. Even home remedies like tulsi, ginger, various kadhas, it's very comforting for the child. Influenza. Now, influenza is basically caused by an orthomyxo single-stranded RNA virus. There are 3 types, A, B, and C. Now, we are really not concerned with C because it doesn't really cause that many infections, and especially it's really not seen in the pediatric age group. So we're concerned with A and B. Now, influenza type A causes moderate to severe disease even in children. And it is again, you know, it's classified on the basis of the H and the N. The H is the hemagglutinin and the N is the neuraminidase. The mild disease, the B causes mild disease. 40% in less than 5 years old children is caused by the B type. These symptoms are much more mild. So what you'll have is an acutely sick looking child. He's having sniffle, this cold, this cough, there's a blocked nose, and the child is goes into tachypnea and having respiratory distress. Now you'll send all these septic markers and you'll be surprised that the septic markers are quite normal, on the lower side in fact. But you look at an X-ray, then you will have X-ray findings. You'll have chest findings when you auscultate. And then when you finally send the swab for the viral panel, you will get some virus or the other positive. So in India, the disease burden is up to 10% of all ARIs. By ARIs, I mean acute respiratory illnesses. These are secondary to influenza infections. And especially the ones that are caused by the type A influenza virus can sometimes be moderate to even children requiring ventilation. I've even seen that spectrum as well. So signs, we generally tell parents, a flu, a cough, a cold, a fever that's not subsiding in 3 days. You've given home remedies, you've given paracetamol, you've kept your child hydrated, but it still comes back. There's a sore throat, the body aches, the child is very tired and fatigued. Please come to the hospital. Warning signs of influenza: shortness of breath, chest pain, dizziness, excessive vomiting, and the chest X-ray findings are out of proportion to the septic markers. So you'll have a CRP which is like 2 or 3, but the chest will show bilateral infiltrates, pneumonia and things like that, typical viral pneumonias. General prevention care for monsoon diseases. Number 1, safety of food, vegetables and water. Again, I say, parents ask me, should we wash vegetables and fruits with the available disinfectants? I say no, clean water is just enough. And if you really want to be a little more careful, you can actually soak those fruits in water for maybe half an hour, wash them again with clean running water, and they're good to go. Sanitation, disposal of waste, hand washing before eating, before cooking, and vaccines wherever applicable. Water safety, so there would be, KMC wise, I mean, a corporation chlorination of water, domestic chlorine drops, boiling water filters, monitoring of the water quality, which we are now able to do because we have these RO systems and aquaguards and Kents and all that in our homes. So those people who come to do the servicing will tell you how much are the total dissolved solids and this and that. So we need to definitely monitor the water quality. If you're outdoors, it's good to use a good quality mineral water. So food safety, hand washing, around our houses, within our houses, in our washrooms and garden areas, we need to do periodic cleaning, avoid any stagnation of water, especially in coconut shells, old tires and old containers. We need to contain those things because they are going to be breeding ground for mosquitoes. To avoid mosquito bites, using nets, meshed doors and windows, various repellents which are available, which are safe even for babies, mosquito rackets and fogging grounds which are done by the corporation. So I'm just going to deal with these 4 vaccines, and then the last one is another vaccine which is of a different category. These 4 vaccines are vaccines to diseases which are do show a spike in the monsoon season, as I discussed each of these maladies. So I'll be talking about the Rotavirus Vaccine, which is a preventer for the rotavirus diarrheas, which are killer diarrheas. Influenza Vaccine, the Hepatitis A vaccine, which prevents viral hepatitis A, and the Typhoid Vaccines. These vaccines have really evolved over the last couple of years. And what we have now is really technically advanced, very sound vaccines with pretty high protection rates. So we'll talk about the rotavirus first. As we know, all oral vaccines that are given in children, they are all live vaccines. For example, the other vaccine which is given oral is the oral polio vaccine, which again is a live vaccine. So with a live vaccine, you have to be very careful that the temperatures are maintained, and next that the child does not have any kind of immunodeficiency or is not in any high risk. So it's important to take a good history from the parent regarding the ailments of the children, so that a child with an immunodeficiency will not be given any kind of a live virus. This vaccine is stored at 2 to 8 degrees centigrade in the refrigerator 2 to 8 degrees is the middle shelf of the refrigerator, stays well there. Of course, we have to ensure that there is no useless opening of the door of the refrigerator so that the temperatures do not vary. Also, in our hospital, we follow continuous checking system. At least thrice a day, the temperatures of the vaccine fridge in our pharmacy is checked. We maintain a register for that. And we have a thermometer which is calibrated regularly. Now, the rotavirus formulations are, we have Rotavirus, which is the monovalent against one strain of one serotype of rotavirus. And we have Rotatec, which is the pentavalent vaccine. Rotovac and Rotosil are the Indian vaccines. Rotavirus again comes from Europe. Rotatec comes from the United States. These were the pioneers in the rotavirus vaccines. And India had conducted a study, multicentric studies. I had been part of that research study. It was done in the ID hospital at Beleghata. And I did some of these statistical analysis for these studies along with Dr. Dilip Mahalanobis. So Rotavac is the Indian vaccine. Rotasil is the Indian vaccine, and they claim that the vaccine produced by them is even stable at 40 degrees centigrade. That is our normal Indian summer temperature for 3 to 6 months. Sorry, just give me a minute. So the efficacy of this vaccine is anywhere between 50 to 80%. And the schedule is, we club this vaccine, the monovalent one, that is the Rotavirus, at 6 and 10 weeks during the immunization schedule along with the DPT vaccine. Now, this Rotavirus is a freeze-dried form. They give the dilute, we dilute it, and then we put it into the baby's mouth. The pentavalent vaccine is the one which I prefer using, and that's what we stock. We also stock the Rotavirus, and shortly I will try and make even the Indian vaccines available because of the cost factor. And the pentavalent vaccine is given at 6, 10, and 14 along with your first dose, second dose, and third dose of DPT vaccines in the infants. Now, there is an age limit set beyond which you cannot give the rotavirus vaccine. So you can't have a child who comes at 5 years and the parent says rotavirus vaccine nahi hua hai, so can you please give it? So no. So Rotatec, the pentavalent vaccine, you can give it only up to 32 weeks of age. That is about 8 months, 7.5 to 8 months. Rotavirus up to 25 weeks of age. The difference between Rotatec and Rotavirus, monovalent, and Rotatec is that Rotavirus has two dose schedule and Rotatec is a 3-dose schedule. But the seroconversion and the data shows that Rotatec, that is the pentavalent 3-dose schedule vaccine, has better coverage and superior protection against the rotavirus diseases. Now, it is very important that during giving these vaccines that we counsel the patients that it doesn't mean that you're taking this vaccine so bachar kono din patla paikhana, diarrhea, kichu hobe na. Baby will have the normal diarrhea, but this saves from the killer diarrhea which is caused by the virus, rotavirus. Next, we come to the influenza vaccine. Now, influenza vaccine, again, we have 3 types of vaccines available in the market. In India, only 2 are available. So, we have the inactivated vaccine is what we use, and the live vaccine. Also, the recombinant vaccine is given to those above 18 years old. So, that's not the age group that I treat. So, we use the inactivated split virion vaccine. So the various names under which it's available is Fluarix Tetra, the current one which we are using, Vaxigrip, Fluquadri, Influvac, and so on and so forth. The IAP recommends that we give 0.5 ml as an IM dose. Now, the reason why I have termed it as universal dose is because until last year, what we were doing was the vaccine was available in 2 strengths, a syringe, pre-filled syringe of 0.25 ml, and there was a pre-filled syringe of 0.5 ml. The IAP recommendations and WHO recommendations as well was that children from babies from 6 months up to 3 years would receive 0.25 ml IM, and 3 years to whatever till age group could take it, it would be 0.5 ml. Now, in the last meeting of the IAP, which occurred in 2021, just after the pandemic, they decided a universal dose of 0.5 ml because the seroconversion was much better with those who received the 0.5 ml dose. So the first dose of the influenza vaccine can be started at 6 months. We give the second dose at 7 months. Now the IAP recommends that during the first year of life, it's 2 doses, and after that, it's a yearly vaccination. Now, why is this vaccine given on a yearly basis? I think as far as we go back to our microbiology days during our MBBS, we remember the antigenic shift and the antigenic drift. The antigenic shift, as it suggests, these are small changes in the antigenicity of the virus. So it's a small load of disease, smaller rise in numbers. Antigenic drift, and these would cause like epidemics, local epidemics. But the antigenic drift would be large changes in the antigenic structure of the virus, and therefore these cause a large pandemics. And so taking this into consideration, the virus keeps mutating and the antigenicity changes, and therefore it demands for yearly re-immunization. Now there are 2 sorts of vaccines. If you, the next time you take your kid or you go for an influenza vaccine yourself, if you look, the WHO sits every year and then they divide the vaccine into 2 groups. One is Northern Hemisphere and Southern Hemisphere. So on the vaccines that are available in India, it will be Southern Hemisphere because we fall in our country falls in the Southern Hemisphere. And the WHO actually meets twice a year, in January and sometime in September, August, September. And they decide on which strains they are going to produce the vaccine against. So therefore, you see around October, there'll be the new vaccine, and in the Northern Hemisphere countries, in about February, you'll get the new vaccine. That's the time when the disease actually spikes. So if the protection starts within 4 weeks, and those who are already primed, the protection starts within 2 weeks. Protection is pretty good. It's up to 60%. Now we come to the hepatitis A vaccines. Now most people confuse, at least most parents say, no, we've already got hepatitis A in the first few months of life. So it's not hepatitis A, that's hepatitis B. So hepatitis A is quite a different virus. This is against the commonly called jaundice, and it's hepatitis A virus. There are 2 types of vaccines available: the inactivated vaccine and the live attenuated vaccine. We are stocking both the vaccines in our hospital. So the inactivated vaccine, it's a dosage of 0.5 ml in children less than 18 years of age. Once a child crosses 18, has never taken a hepatitis A vaccine, no problem. We can still do a catch-up immunization, and we'll give 1 ml of the vaccine to the adult. So earlier it was available as Havrix 1440, but now only 1 strength comes. That's Havrix 720 Junior. So if an adult wants to take it, we have to give 2 vials, that is 0.5 ml plus 0.5 ml equals to 1 ml. It's an intramuscular vaccine, no side effects, no fevers, no rashes, at least none that I have ever come across in all these years of using the vaccine. Usually the first dose of the vaccine is administered after the baby just crosses his or her first birthday, and the next one is given 6 months, 4 to 6 months after the first dose. The live attenuated vaccine comes under the name of BioVac A. This vaccine, unfortunately, is a very good vaccine, but it has gone into disrepute since the pandemic for the simple reason, or the single most important reason, that this vaccine was manufactured in China versus the inactivated vaccine which is manufactured in Europe. So the live attenuated vaccine is available under the name of BioVac A. We do stock it in a smaller quantity in our pharmacy because there are some parents who ask for it. Also, the dosage is 0.5 ml. It's a single dose. You don't need a second dose, and it is given, the route is subcutaneous. So storage for both these vaccines is 2 to 8 degrees, middle shelf of the fridge. Both are equally effective. It shows a seroconversion of 95%. Protection starts within 2 to 4 weeks of giving the vaccine. And if you want to check after a hepatitis A vaccine, it's the same as a hepatitis B vaccine. We check antibody titers. So when you're going to endemic regions, then when you check the antibody titers, hepatitis B, you need 10 units, 10 milli international units per ml. But for hepatitis A, it is 20. For B, it is 10. Typhoid vaccine. So the typhoid vaccine, this is the last vaccine among the section of the monsoon maladies which prevent the diseases which rage and rise in the monsoons. So it prevents typhoid, and this has an interesting history. If you recall back in the 90s, in our microbiology textbooks, it was written that the prevention for typhoid was clean drinking water, sanitation, blah, 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 and a vaccine which was called the Typhoid Vaccine. It used to come in a strip of 3 capsules. I remember taking it when I was in medical school, and you had to take it on every alternate day, and the protection would last for about, I think, 1 or 3 years, something like that. Then they went on to the injectable form. It went out of the market, and the injectable form, the VI vaccine, was initiated into the market, and it was there in the pediatrics scenario also, and it had to be given, the booster had to be given every 3 years. Recently, in the last couple of years, they have come out with the VI polysaccharide conjugate vaccine. What do you mean by conjugate vaccine? By conjugate, we mean that the VI antigen against which the antibodies are, antibody production is targeted, is conjugated or linked or sort of carried by a conjugate. A conjugate may be anything. It may be aluminium. It may be a virus component. But this vaccine is a TT conjugated vaccine, storage of 2 to 8 degrees, dosage again 0.5 ml intramuscular. Sometimes we do have children. Suppose you give it to about 10 babies, you may have one child who will complain of a little fever or extra pain or something like that. Route is intramuscular. Protection starts 1 week and reaches a maximum at 4 weeks after immunization. Efficacy is good, 50 to 70%. And even if a child who's immunized does get typhoid, it's going to be a very, very mild sort of infection. The age is now the IAP. Earlier, it was the first dose was given at 2 years and second dose was given at 5 years. With the DPT vaccines, along with that, it was given 2 years. Of course, it was a standalone, and at 5 years, along when they came for the booster. Now they have said that the VI polysaccharide conjugated vaccine is even safe at 6 months. So you can give it at 6 months, which makes sense because the baby is going to be ideally introduced to new food, which is going to be prepared, cooked in the water that is available at home. Sometimes parents travel with their children. So the child is going to be exposed to outside food and water. So 6 months to 2 years. For some time, for a couple of years, we followed the 2-dose schedule, 2 years and 5 years. Then we said 1 year, that means 9 months and 2 years. Now, even that has changed in the last meeting of the IAP, with the IAP saying that only a single dose of the VI polysaccharide conjugate vaccine is sufficient. And you can do a catch-up even up to 15 to 18 years. No booster recommended. Those are the latest guidelines. What's new in the market in the vaccine scenario? I'd like to take just 2 to 3 minutes and go through it. It's the Gardasil. It's the all-new Gardasil vaccine, which was much the talk of the town until it recently arrived a couple of few months ago, 2 months ago or so. So it's the Gardasil 9 vaccine, and it's very commonly known as a cervical cancer vaccine. Now, Gardasil, this Gardasil 9 is called the gender, I'm sorry, there's a spelling mistake there. It's the gender neutral vaccine, and it protects against the human papilloma virus. And earlier it was thought that the human papilloma virus was one of the main causes of genital warts, vulvar carcinoma, vaginal carcinoma, cervical carcinomas in women. And so the teenage female, the girl group was targeted, and people vaccinated them. Now, for quite some time, of course, in the United States and other Western countries, the 9-valent vaccine has been used, which has now come to India. So the 9-valent vaccine is called the gender neutral vaccine because it is advocated for use in boy children as well, in adolescent males as well, because this has been used and they have done a number of studies showing good seroconversion, good protection rates. So in males, it protects against anal carcinomas, penile carcinomas, genital warts, and even oropharyngeal carcinomas. However, as far as the oropharyngeal carcinomas are, they really haven't set a percentage. The numbers are still under review. So what type of vaccine is this gender neutral new vaccine that we have in the market? So it's a recombinant vaccine which is prepared from virus-like particles, VLP, of the major capsid L1 of the human papilloma virus. And the HPV types, proteins types that are used are 6, 11, 18, 31, 33, and so on. Storage of the vaccine, again, between 2 to 8 degrees, middle shelf of the refrigerator, and there are specific directions that do not freeze this vaccine. The dosing schedule, and this is the same for both boys and girls. So the initial doses is best initiated at 9 to 14 years. When it's given between 9 to 14 years, you need only 2 doses. One is the 0 dose, which is the first dose, and the second dose can be taken anywhere between 6 to 12 months after the first dose. The next group is the 14 years to 45 years. Ideally, if you read the data, it says that it's really not all that effective after the age of 20-25. So insurance companies in the US do not pay for it after the age of 25. So in that age group, there are 3 doses of the vaccine which are required, the 0 dose at 2 months and at 6 months. Now, initially we had until recently, and we still have in stock, the bivalent vaccine, which was used for all those who wanted to take the vaccine. It's an optional vaccine. It was called Cervarix, and it was used here. And the tetravalent vaccine never really came into India. And then now we have the 9-valent or the perfect Gardasil 9 vaccine. So the side effects are very minimal, and the company also has a adverse effect reporting unit, and people can, individual clinicians and patients even can report adverse effects. So that's as far as the Gardasil vaccine. The only other disadvantage to the cost is a bit high, but I'm sure with the coming of the vaccine and certain duties being curtailed, it will come down in due time. Thank you very much.
Thank you, Dr. Nicola. You'll all will agree that she has made a wonderful presentation. Dr. Nicola, can you withdraw your slides, please?
Yes, sir.
So while she is doing it, she has presented what can go wrong with children in monsoon and what are the early signs. Now, I have a few questions, Dr. Nicola. That for a parent, for a young parents, you are 25, 30, 35, how do they differentiate? What are those very alarming signs they should look at? Child who's under 1 year and 1 to 3 years and above, that where they must consult a doctor, must go, like you said that in malaria, the fever comes with chill, can come with a chill. In typhoid, the fever doesn't break. In in dengue, there could be rashes. So what are those warning signs where the parent should look for and consult a doctor on priority?
So as far as the fevers are concerned, sir, we advise parents who are young parents,
yes,
first-time parents, who have children who are less than the age of 3, that any sort of fever that is persisting beyond 3 days, please do not treat at home anymore. Please go to a health facility, come to us, come to the hospital and have it checked out. Because in a child that small, it's even difficult to appreciate tachypnea because their respiratory rates are anyways higher than ours. Sir, you're on mute, sir. I cannot hear you.
Sorry, I had to take a call, which I just couldn't avoid. The part of our life, professional life. Right. So, Dr. Nicola, which is the one symptom when the child, when he's under 1 year, parents should watch for when they have a fever? One sign.
One sign would be, sir, the change in the behavior. If there's any sort of lethargy, an normally active playing child suddenly becomes very tired, fatigued, not doing his normal activities. I think that is the one thing that will tell you that the child is not well.
Very good. Even if he doesn't have fever or fever is subsided, like dengue, the fever subsides. So one is the change of behavior is the sign which is the most dangerous sign.
The activities are to be precise.
Okay. Very good. Now about the vaccinations. How often these vaccinations should be repeated? I mean, what are the...
Each one has a schedule, sir. Like the typhoid vaccine, we were giving 2 doses up to now. Now with the recommendations coming, we will upgrade our vaccine card to making it only 1 dose.
So typhoid is 1 dose?
1 dose, sir.
For lifetime?
For at least up to 18 years, we say, because the studies and the numbers that we have on paper don't really show us very long data.
So in a pediatric age group, once they are vaccinated with the new typhoid vaccine, up to 18 years, they are safe with typhoid.
Yes, sir.
Relatively.
The antibodies are high.
Relatively, okay.
Yes, sir.
Okay. Next, influenza.
So influenza, like I said, sir, because of the antigenic shift and rifts, it's a yearly immunization. So it's better to take the immunization because, nowadays the travel has become, the global travel has increased so much. So people are actually globe-trotting, and obviously children do accompany parents. And children need to be protected, especially when they are going to colder countries, where in India also, so it's in the last few months, we've had influenza cases here in our unit as well.
So a new influenza vaccine comes around October, and there is time when every child should take influenza vaccine. Is that what you are saying?
Yes, sir.
And what is the minimum age when the influenza vaccine should be given?
So they just start at 6 months. We give 1 dose at 6 months, the next dose at 7 months, because in the first year we give 2 doses. And thereafter, every year of life is 1.
Then the hepatitis vaccine?
So hepatitis, again, there are 2 types. So we are stocking both types. If you take the inactivated vaccine, which is a European vaccine, you need 2 doses. So ideally, 1 is taken at just after the first birthday, and the next one is 6 months later. And if you take the live vaccine, which is a China-made vaccine, which people just don't want to take because it's made in China, so that is single dose at 1 year.
And then it doesn't have to be repeated again?
No, sir.
It's a lifelong.
It's lifelong. And even bigger children who come back, maybe children like 14 years old, 10 years old, have not taken the vaccine when they are kids. Now they come to the city, they are living, parents are aware. They come, we do the catch-up vaccination for them also.
So we have covered typhoid, we have covered influenza, we have covered hepatitis.
Yes, sir.
And so now I want to ask a question, how pertinent it is for every boy and girl to be given the Gardasil vaccine to prevent cancer in future in them?
So if you look at the Indian data for cervical cancer, and I'm sure my colleagues in obstetrics and gynecology will agree, the incidence of cervical cancer has gone up. It's like a linear spiking increase, and over the projected increase over the next 25 years is also very high. So it is very pertinent, sir, but in India, cost is a factor.
How much it costs?
So the new vaccine, the old vaccine which we were giving, the 2-valent, that was costing 3,000 something, sir. And the new vaccine is 10,850 per dose. So it is an amount. So actually, the Indian immunization, the government, the peripheral health centers, Swasth Kendras, the vaccines they give the children the basic vaccines. Now, all the other vaccines, which they term as optional vaccines, are not optional because these diseases don't occur in India. They do occur. It's optional because of the cost factor, because we are still haven't reached the stage where we can give even those vaccines as part of our schedule.
This vaccine costs much cheaper than the iPad we give to our children.
Yes, of course, I do agree to that. Parents should look at it like that.
Yeah, and if it prevents, yes, I understand the poor and middle class may not be able to, lower middle class may not be able to afford it, but then those who can afford an iPad or mobile phone, they can certainly afford it, because that will save your child from sure shot cancer in
Yes.
future. And with the way the cancer is rising, cancer is not going to be, it's becoming endemic. There was a time when none of us knew about cancer and we had not heard of anybody. But I'm yet to see now any family which is untouched. Everyone knows that somebody in the family has got a cancer which is very close to them. So if you can prevent a cancer by single or two jabs before the age of 14, nothing can be a better gift to your child than the vaccine.
Actually, in fact, we are starting the vaccine drive here with, sensitizing our own fellow employees regarding the vaccine, and, telling them that, well, this is available here. And also our plans are that, we are trying to drop certain packages for vaccines where our hospital will be different to others, giving sort of packages, and there'll be good discounts. And so that's encouraging parents to actually just join up for these packages and get their children completely immunized. Also, our storage methods are very stringent, because I myself keep a check on the pharmacy vaccines. I check the temperatures myself, and I check the storage. So we are maintaining a strict cold chain there.
Thank you, Dr. Nicola. Thank you. You all will agree that Dr. Nicola has presented very lucidly that what makes a child sick in monsoon, how to prevent it. Not only that, in monsoon, she has also given some tips how to keep them healthy and prevent common diseases for the rest of their lives. With this, we come to the end of our webinar. With thanks to Dr. Nicola, thanks to our supporters who have been helping us in spreading the knowledge to the common man. Thank you very much for joining us. Have a nice week.
Thank you, sir.
Thank you.
Thank you, sir.